This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that hits home for anyone managing peripheral nerve pathology.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study protocol from BMC Surgery, published recently in 2026. It's titled End-to-Side Anterior Interosseous Nerve Transfer Augmentation of Ulnar Nerve Function in Moderate and Severe Cubital Tunnel Syndrome, a randomized controlled trial protocol.
This is a timely discussion, Alara. Cubital tunnel syndrome, or CUTS, is the second most common compression neuropathy we see in the upper extremity. In 2020 alone, there were over 9,000 surgical procedures for this in England. Yet for our patients with moderate to severe disease, simple decompression doesn't always yield the home run results we hope for.
Exactly, Dr. Aris. The paper points out that while sensory symptoms like paresthesia and numbness in the ulnar digits are typical, the real challenge is the motor loss, weakness in the flexor carpi ulnaris, or FCU, and the ulnar flexor digitorum profundi, but especially the intrinsic motor weakness that ruins a patient's delicate finger control and key pinch grip.
Right. And the paper sets the stage by reminding us of the 5 potential sites of ulnar nerve compromise at the elbow described by Posner back in 1998. Just for the residents listening, that's the intermuscular septum, the medial epicondyle, the epicondylar groove, the cubital tunnel itself, and the exit of the ulnar nerve from the FCU.
The pathophysiology is what really drives the need for this study. The authors describe how prolonged compression produces an injury with conduction block due to ischemia, which then leads to progressive demyelination and axonopathy. They go into detail about Wallerian degeneration, where the axon is lost within its endoneurial tube distal to the injury site. Once that happens, the distal axon can't maintain membrane integrity. Water enters, the cell swells and ruptures, and macrophages have to phagocytose the remnants.
And that's the crux of the clinical problem. Even after we decompress the nerve, functional recovery can be stalled. The paper mentions several reasons for this: chronic axon cell loss through apoptosis, intraneural fibrosis, long reinnervation distances, and what they call Schwann cell senescence. Essentially, by the time the regenerating axons reach those intrinsic hand muscles, the environment is no longer receptive.
Which brings us to the innovation in this protocol, the supercharge end-to-side, or SETS, nerve transfer, specifically using the anterior interosseous nerve, the AIN, to augment ulnar function.
This is the ETS technique they are investigating. Now, Alara, the paper notes that this is controversial. Why is that?
Well, there's a lack of equipoise regarding its efficacy. While retrospective cohorts and single-arm studies suggest it works, there's persisting uncertainty. We don't know for sure if the functional recovery we see is from the decompression itself, from collateral sprouting of terminal axons that were still intact, or true neo-innervation from the AIN transfer.
That's a vital distinction for a surgeon. We don't want to add surgical time and cost if we can't prove the transfer is doing the heavy lifting. This is why the authors have designed this specific RCT.
Right. This is a prospective single-center RCT. They are recruiting 20 patients who will be randomized to either standard ulnar nerve decompression alone or decompression plus the ETS-AIN nerve transfer. One of the key aspects of the study design is participant blinding. The patients won't know which treatment they received.
And they are looking at a long follow-up, right?
Yes, up to 24 months. Because this is a pilot RCT, their primary goals are to assess recruitment, protocol compliance, and subject retention. They want to define the sample size needed for a much larger future multi-center study.
Let's look at the classifications they mentioned. Historically, we've used McGogwan-Goldberg and Dellon to classify severity. These are based on symptoms and clinician opinion, but they can be subjective. This study is specifically targeting those with moderate and severe ulnar neuropathy. For the practicing neurosurgeons listening, that usually means patients who already have measurable weakness or muscle atrophy.
The paper notes that if this trial demonstrates significant functional benefits, it could fundamentally shift our clinical practice. Instead of just waiting and seeing after a decompression, we might move towards this dual approach as the standard of care for severe cases.
It would certainly optimize patient outcomes if we can bypass that Schwann cell senescence we talked about. By bringing a donor nerve, the AIN, closer to the target muscles, we're essentially shortening the distance and the time the muscle is denervated.
And the AIN is a great candidate because it's functionally expendable in many ways when transferred distally, and it's anatomically proximal to the ulnar innervated intrinsic muscles in the forearm wrist area. The paper emphasizes evaluating procedure-specific risks and additional costs, because adopting an innovative technique has to be balanced against the safe delivery of care.
I also found it interesting that they mentioned the willingness of clinicians to randomize. In the world of peripheral nerve surgery, many surgeons have a strong gut feeling about these transfers. If the study shows that surgeons are hesitant to randomize, it tells us a lot about the current state of belief in the SETS technique.
Exactly. They registered the trial on the ISRCTN registry, number 1837903 for those who want to look it up, back in May 2024. This shows they are committed to a high level of transparency.
It's a rigorous approach to a difficult problem. To summarize for our residents, we have a high-volume condition, cuts, where our standard surgery sometimes fails the most severely affected patients due to the biology of Wallerian degeneration and the long distances axons must travel. The SETS AIN to ulnar transfer is a supercharge designed to fix that.
And this RCT protocol is the necessary step to move from "it seems to work in my hands" to "this is evidence-based medicine." They are looking at the relative contributions of decompression versus neoinnervation.
It's about finding that equipoise. If we can prove the AIN transfer provides a significant functional boost to key pinch and power grip without added morbidity, it changes the treatment algorithm for every moderate to severe cubital tunnel patient that walks into our clinic.
I think it's also important to note the collaborative nature of the study. Authors from Birmingham, Amsterdam, and Rotterdam are involved. It shows that this uncertainty about the ETS technique is a global conversation in hand and peripheral nerve surgery.
Well, Alara, this has been a great deep dive into a very specific high-yield protocol. For the medical students listening, remember those 5 sites of compression at the elbow. They are a favorite board question. And for the residents, keep an eye on this study's results in 2026. It might change how you're consenting patients for cubital tunnel release in the future.
Definitely. The goal is to move beyond just stopping the progression of the disease and start focusing on more reliable functional restoration.
Well said. That's all the time we have for today's episode of the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. Thank you for listening, and we'll see you in the next episode.